close monitoring, counseling, correction of anemia, and planned delivery depending on the type of twin. So what about screening? Moving on to screening. So the best way of screening for preterm birth, as we mentioned yesterday, is having a cervical length assessment in the anatomy scan. All societies recommended that multiple gestation should have at least one cervical assessment during anatomy scan. You can do it as early as 14 to 16 weeks, and we take the cutoff of 25 millimeters as a cutoff for interventions like large versus vaginal progesterone. In my setup, definitely in monochorionic twins, because they are at high risk of preterm labor, we do repeat the cervical length every 2 weeks. In the dichorionic, there's no much roles, but I do it in a monthly scan to pick up any sudden shortening of the cervix, so interventions can be done on time. Okay, what about monochorionic complications? So the first complication I'm going to be talking about is the twin-to-twin transfusion syndrome, where there is a recipient and a donor. So a donor gives and the recipient takes. Okay, and this is because of imbalance of the atriovenous malformation or perfusion. So you can see here, you can see the membrane, yes? See the difference? No much fluid, almost, and here are lots of fluid. So this is the early stages of twin-to-twin transfusion, oligohydramnios, polyhydramnios. I don't know if it's stage 2, because I cannot see the bladder, I cannot comment on it, but at least definitely it is maybe stage 1, unless we spoke about growth discordant with one having structural abnormalities. You can see how the baby is stuck here, really stuck. This is the membrane, and there's no bladder. Okay, so this is at least stage 2. Stage 2 I'm comfortable with, there's no bladder and the other one has bladder, and I'm definitely sure it's twin-to-twin. What is happening here? Today we saw some thickening of the skull, it's hydrops. So which stage do you think of? So stage 1 we said the discordance in the fluid. Stage 2, bladder. Stage 3 or 4, this is 3 or 4, 3. Abnormalities in the Dopplers, 4 is hydrops, and 5, unfortunately, death of one or both twins. Okay, so it happens usually in 10 to 15% of monochorionic diametric twins, less commonly seen in monochorionic monoamniotic twins, because in monochorionic monoamniotic twins, they have very strong, good arterial anastomosis, which overcome the imbalance which happens in the monochorionic. So what happened here, usually, I don't know how to explain it, but to have, you can see as if you're splitting the placenta into half. Okay, you split the placenta into half. So you expect twin A will get enough venous flow and arterial flow, while twin B will have a balanced flow. In most of the cases, if there is slight imbalance, for example, A has more little bit of blood flow to it, and B has less, the arterial anastomosis or vessels open up and give. But these arterial vessels, if they're not enough, one of them unfortunately will be, they say like, poor thing, they're not getting enough nutrition or not enough oxygenated blood. So that's what happens, then the twin-to-twin transfusion. That's the concept of treating. So the best treatment is, I'll talk about, is laser ablation, but people talk about conservative, do nothing, but maybe might survive. 50-50. You can do amnioreduction. What do you mean amnioreduction? Remove the fluid, the polyhydramnios fluid. And when you remove the fluid slowly, the pressure, because of the sudden pressure, some of these vessels open up. So helps the other. This is a temporary thing, you understand? Not like laser, when these anastomosis can be burnt, but of course you have to be having a good place when they can do it, because also it has its complication. So unbalanced vascular anastomosis, more directional AV anastomosis than bidirectional AA anastomosis leads to this concept. That's why only 15%. Luckily, the other 85% do well. It's of course diagnosed by ultrasound, commonly seen between 16 to 20 weeks. Usually by 28 weeks, if you don't see it, it's unlikely to see twin. So you're happy, but you're worried about the other complications when we said TAPS, the twin anemia, polycythemia. So we spoke about this. So what classification you should use on ultrasound? You call it Quintero staging, stage 1, oligopoly, with a normal Doppler, stage 2. The donor will have no bladder, no visible bladder, or small, and the recipient will have a large bladder, a normal Doppler. Then stage 3, abnormal Doppler with all other signs on ultrasound. Stage 4 is the hydrops. Usually it could start as an abdominal ascites. And then unfortunately stage 4 is a device of the fetus. The best time is to do any intervention, the outcome is the best with stage 2 and 3. Stage 4 and 5 still, there are studies that show the outcome can be okay, but not as good as stage 2 and 3. So when you do the first and second trimester sonographic ultrasound, you will find some signs that might say, oh, these are the fetuses, these monochorionic fetuses are at risk of having twin to twin. So if there's crown-rump length discordance between the twins, this is an issue in the first trimester. If the nuchal, the NT or the nuchal translucency is more than 95th centile, if one of them or the difference is more than 20%, then you're concerned they can have twin to twin. Reversal or absence of ductus venosus A form. This is the first trimester. In the second trimester, if there's growth discorder between the abdominal circumference, membrane folding is a shape, but not very commonly seen. Filamentous placental cord insertion in the donor, twin placental echogenicity donor portion. They're very hyperechoic usually in the donor. So this is one of the largest, the urine fetus group, the European Society, looked at the outcome of laser treatment, but they looked at only stage 2 and 3 in 172 women, and they stopped actually a randomization in 142 weeks. What they did, laser versus conservative, doing nothing, and they saw there was a major difference in survival rate of more than 15%, and that's why they said it's the best thing is to do laser for these fetuses. And also the more further studies were done in all various stages by the European, Australian, and the North American societies or groups, I mean. Actually, Toronto is one of the highest referring center for in Germany for Europe, and Toronto for North American. And as you see, the survival rate is best for stage 1, then it goes down per stage, and this is logical, it makes sense, you know. So, but they don't do it, of course, for the stage 5, which is the death of the twin. There's no point, too late. So moving on, we finished the twin-to-twin transfusion. We moved to twin anemia polycythemia sequence. So it's a variant of atypical chronic form of twin-to-twin transfusion. When it happens later, a little bit of these unidirection, bidirection flow imbalance, they might end up with a TAPS. The TAPS usually occur in the late second trimester and early third trimester. And how do we diagnose it? By the difference of the middle cerebral artery peak systolic velocity. So the donor will have more than 1.5 MOM, multiple of medium value, while the recipient will have less than 1 multiple of medium. And then you're sure one is having polycythemia and one is anemia. If it's late, if it's in the later gestational age, you can deliver them. If it's early, then again, that the donor might need fetal blood sampling and transfusion. And twin anemia polycythemia sequence, but these are usually at late stages. There are some ultrasonic features in placental, as I said, echogenicity. You might see one placenta. You can see here it's bright, very bright, and echogenic and thick. While with the recipient, this is for the donor, with the recipient, see thin and echolucent, a little bit lighter placental and thinner placenta image. Same with the liver. The body, I have not seen it because this is very rare. Twin might have a starry sky appearance of the liver pattern due to diminished echogenicity of the liver parenchyma and increased brightness of the portal vessel. So you might see some echogenicity in the liver. So now you can see the difference in the middle cerebral artery. One is the donor and showing the risk of the anemia, and one is like very low middle cerebral artery Doppler. And the reason why, because the one will have low hemoglobin, and the recipient will have high hemoglobin values. So there are stages actually of TAPS recently documented. The stage 1, when the middle cerebral artery Doppler is 1.5 and the other one is, for the recipient, is less than 1. Stage 2, when it's worsened, the difference. So that usually the hemoglobin for the recipient will be within the normal range, almost 17. So these are the early stages. In stage 2, the hemoglobin for the recipient, the polycythemia will be shown more, it's 14. In stage 3, the hemoglobin, the difference will be higher in the middle cerebral artery systolic, but there will be cardiac compromise. So you will see some abnormal ductus venosus or absent and reversed vertical artery Doppler, and the hemoglobin at that time will really go down to 11. And then by the stage 4, then the hydroxy hemoglobin is lower than 8 grams per deciliter, and stage, so that was 4 or 5, death of one or both the twins, unfortunately. But these are very rare, as I said. TRAPS is not very common. What about TRAP? Just a word. It's easy to diagnose. It happens it's very rare in the monochorionic, 1 in 35,000 deliveries, and it affects 1% of monochorionic pregnancy. A twin with an absent or non-functioning heart, a cardiac twin, is perfused by its co-twin pump twin by placental arterial anastomosis. So this here will be the arterial anastomosis. So one will be a pumping twin giving blood, deoxygenated blood, to the lower torso of the baby. So there's, upper torso, there's stages also, I'm not going to go through the details, so that it's not formed. There's no skull, there's no calvarium, there's no brain, there's no even heart. Some will be partially developed, some will be abnormal. So this is what I said, perfusion of deoxygenated blood from the pump twin to the lower half of the recipient twin via its iliac arteries. And poor perfusion, it happens. Okay, so this is just a picture to show you. This is the normal fetus, and actually this early in the first trimester, you see the nuclear transmission is high because it's pumping blood. And you can see this is like amorphous, like a blob. You see like a fetus with nothing, no brain, no heart, just the lower torso. Sometimes even the lower limbs are not developed. Again, the same picture, but here, what I want to show you, there are criteria you can treat there's certain criteria. And the prognostic, if the prognosis is poor, maybe you try to help by cutting the blood supply or these anastomosis from the amorphous twin or the recipient twin, and the donor, the pumping twin, might survive if you do either laser treatment ablating these anastomosis, or you do radio frequency, which is very done by ultrasound treatment, or coagulation also. Again, same picture to show you the difference. Nothing, no head in the twin B. It's like just a lower limb. The bladder you can see, maybe a little short limbs, but you cannot see, and no heart and no brain tissue. So in the TRAP, usually the recommendation doing weekly ultrasound is required, twice a week if early evidence of heart failure. How do you know? By ductus venosus. Antenatal intervention, or conservative or delivery depending on the prognosis. Steroids, most of the women, you'll decide maybe to terminate the pregnancy, consider steroids, and karyotype of twin. Before any intervention, do a karyotype to exclude any chromosomal abnormalities in the pump twin. There's no point if the pump twin is affected with the chromosome that you do this. So what is the poor prognostic indicators? If the ratio of weight of the acardiac twin to weight of the pump twin greater than 0.7, that means the pump twin is smaller. The cardiac failure in the pump twin is very obvious by ductus venosus, hydrox in the pump twin, monoamniotic twins. So these are really very poor prognostic indicator. Why I'm telling you that? Just to pick it up, but it's not, as I said, it's very complicated, should be dealt in a tertiary health institution. Lastly is the monoamniotic. Do I have time?
Yes. Monoamniotic twins.
5 minutes. Monoamniotic twins, incidence is 1 in 10,000, affects 1 to 5% of monozygotic twin pregnancy. As you know, we have dizygotic twins, and the most common is the only twin is di-di. The monozygotic will have dichorionic, diamniotic, monochorionic, diamniotic, mono, or conjoined twins. The monochorionic diamniotic is the most common, the mono, and the conjoined is the most rare, and the monoamniotic is only in 1 to 5, luckily in 1 to 5%. But the problem is its complications. TABs can happen, twin-to-twin can happen very rarely, as I said, less than 1%, but cord entanglement is very, it's almost all, and it could cause consequences. So what do you see? You see cord entanglement is like, I call it like a plait. If women plait the hair, the cords are just together, and it's usually happening, the worst is mid-trimester, because, the lots of fluid, the same sac, they roll into each other. So usually the death can happen in the late in early third trimester, very rarely in the, after 32 weeks. But still, we are very concerned that there is a risk of, and this is one of our cases of mono, and you see how the twins, luckily they survived. We had a study, but still, we had a lot of death and mortalities in these twins. So the mortality rate is around 20%, intensive fetal surveillance. Some recommendation guidance said admit this woman by 28 weeks, give steroids, do CTG 3 times a day because you might pick up some variable deceleration and intervention can be done. Do 2 to 3 times a week by physical profiles and Doppler and growth scans every 2 weeks. Consider antenatal steroid. You have to give antenatal steroid early delivery, and the recommendation now is 32 weeks. All the guidelines have changed, even the 34 weeks. Don't go beyond 33 weeks of gestation. So, what about admission? There's no resources. I prefer admitting this patients, but there are lots of studies looked at, but they're very small numbers because these are rare. And they found that admitting monochorionic monoamniotic twins have improved the perinatal outcome of these fetuses by early intervention, but the number needed to treat was not significant, the p-value was not significant. So these are the indications why they admitted, mainly for elective, but the other indications were non-related.
কারণ চলে গেছে